Um, yeah. Well, thank you for your time. So, I just feel honored to be doing this, with you because I've certainly seen your articles like everyone else that reads any of our literature, and this is kind of might be a little bit of a different focus for you,
Uh,
but so the focus is more on practice management. You're talking about your documentary that you're kind of doing, which is great marketing, and I see your websites, which are great. And so I'm going to be prodding you about that and kind of developing a side business on training and other things like that, if that's okay with you.
sure. Yeah, no, absolutely.
And is it, I apologize, but I have an attending here, Barrett or Barrett?
It's Barrett.
Barrett.
Yeah.
Okay. Hello and welcome to Podiatry Practice Mastery. I have Dr. Stephen Barrett here with me, and thank you for joining the show.
Thank you.
So Stephen, you're in Georgia. You were just here in Maine doing some training on your peripheral nerve work. I want to talk a little bit how you kind of got interested in doing this type of specific surgery. Was it something you chose for yourself or something during your training?
Well, it was kind of one of those things where the path you sometimes go down is not the path that you're specifically looking for. In 1991, we introduced endoscopic plantar fasciotomy, and we really liked an endoscopic, minimally invasive approach. And that procedure, took off pretty well. And then I felt that I hate to say Morton's neuroma because it's not really a neuroma. Let's call it Morton's entrapment.
Uh-huh.
So in 1993, we developed an endoscopic decompression from Morton's entrapment. And then that led me down, starting to do research into peripheral nerve. And then I crossed paths with a gentleman named Lee Dellen, who's a professor of plastic and neurosurgery up at Johns Hopkins. And I was teaching a lot of courses, and Lee and I kind of hooked together. I collaborated with him for, really closely 3 years. He's still my mentor today. I operated in his clinic, his tertiary nerve clinic in Tucson, Arizona for a few years, and just became very, very interested in peripheral nerve. And then, the more you focus on something, the more it, brings just that particular part of practice. So about 95% of my practice right now is strictly nerve.
Wow. Wow. And I was looking on your site. You have a couple of other associates or other doctors that are with you in the clinic as well?
We do. We're building a multidisciplinary approach. So we're really close to bringing on a psychiatrist within the next probably 4 to 6 weeks. And we're also close, same time frame with endocrinology. I have a nerve fellowship program. So we have a nerve fellow. It's a 2-year program through the Association of Extremity Nerve Surgeons. And then I have my partner, who was one of my nerve fellows, my second nerve fellow. Her name is Sequoia Ducasse.
Okay. Wow. And I think we were joking a little bit before. You don't know where to pick your coffee cup up in the morning because you're doing all of this stuff. Are you an entrepreneur kind of by trade, like developing your procedures and all these things, or how did you get interested? You just like learning, or what's the moving factor behind this?
Well, I think there's a lot of moving factors behind, the things that we end up doing. I like the innovation of surgery. I always felt that, and I still feel today, that we can actually improve what we do, even if we, I guess it's kind of like if you're completely happy with what you're doing, then you're probably not improving.
You're probably bored. Yeah.
Yeah. Well, not only bored, but, you just want to try to just basically get patients better with less involvement from a post-operative, comorbidities, these types of things. So the minimally invasive endoscopic approaches were really incredibly satisfying to me.
Yeah.
Because we were able to, turn people around pretty quickly. And just like with anything else, less is more when it comes to surgery.
Yeah, yeah. And so let's talk a little bit about how you have grown this niche in terms of nerve. Because you not only do you do it yourself, but you teach it. You've developed these other organizations. What are some words of wisdom? Did you do it all yourself? Did other people help you? Do you have marketing people that help you? How have you grown this to be how big it is today?
Well, that's a great question, and the answer is I don't think anybody does anything by themselves. I think it, you know, the more we can collaborate and the more we can join forces, there's always the synergistic effect. The the Association of Extremity Nerve Surgeons is a really an organization that is pretty much a de novo organization. It happened because when I was helping Dr. Dellum teach his lower extremity peripheral nerve workshops, these docs that would come to the workshops were blown away by just what they learned. Why didn't I know this? Why wasn't it taught in our regular podiatry curriculum? Oh my gosh, there's all these patients flickering in the back of my mind that I could have told them there was something more that I could do. And so it was probably maybe the third or fourth course that I was teaching with Dr. Dallin, and we were back at the bar, and I remember the place. It was called the Inn at the Colonnades, not far from Johns Hopkins, and they were all excited. And I said, "Well, you guys are all excited. Let's put together some kind of a society or something." And so we went right to a conference room then, and there was probably 6 or 8 of us, and I didn't really take much of a leadership role at that point in time. I wanted to just kind of stand back and let some other people, follow in that path. And then I became really much more involved in the organization, probably 5 or 6 years down the line. And so it has grown. We have different disciplines. We do an absolutely great annual meeting every year. I would encourage, even if people are not interested in nerve, I mean, the speakers that we have, it's a whole different dimension. You'll hear things like how to manage patients from endocrinology standpoint. Not that you're trying to be an endocrinologist, but knowledge is power.
Yeah.
So, to bring these other specialists in, other viewpoints, pain management, this type of thing, it really just empowers you that much more to take care of your patient.
Yeah, no, I think you're right. I think everyone should go to something outside of your specialty, or even this is within our specialty. So there's a little bit of both in those conferences. Those happen once a year.
Yeah, once a year. We also run, for people that are interested, we run an advanced and a fundamental workshop, which is cadaveric based. And then we also have a microsurgery program in affiliation with Mayo up in Rochester.
Okay.
So if someone goes through those programs, then they submit, their cases, then they can become a fellow of the AENS.
Yeah.
And some people really just, nerve is a very seductive mistress, for lack of a better way, for some people.
Stephen, you do a lot of teaching, and I'm just speaking of myself, what the conversation that's going on in my head, I just think, gosh, it just seems too overwhelming to learn all this stuff, and the learning curve. Is that what a lot of people can, like, what's the main reservation for people not going and doing all this stuff? Is that kind of the thoughts that are in people's heads?
Yeah, that's a great question, quite frankly. And I have taught at several levels. I teach undergraduate pre-medical students now, and I've taught first-year podiatry students. We've had residency, affiliations, and now fellowship. So I've been blessed to teach the whole perspective, or the whole spectrum rather. And there's an abyss between intellectual understanding and clinical implementation, and at every level. So you can have somebody that totally gets it, but then when they get into the treatment room with the patient, regardless of what the condition is, even though they may have a very sound conceptual understanding of how to diagnose, how to treat, it's sometimes there's a gap in the implementation. Now, peripheral nerve is very difficult. I spend a lot of time every week, maybe 3 to 6 hours a week, reading other journals, neurology, pain management, anything new, pharmaceutical, these types of things. So it takes a lot of work. And the problem is that the more you learn that you really have much more to learn, and it humbles you very quickly. So But, everybody says, well, aren't you a workaholic? And it's like, no, because I really love what I do. So it's not like I'm going down to the coal mine every day and just working. It's like I get to see these very exciting, challenging cases. So, that I will be very honest with you. When I was practicing more in a general practice, I was pretty bored. I mean, I didn't realize everything else that was out there. And I've had practitioners who've come through the ANS training, and they've said, you saved my professional life, because I was burned out.
Yeah.
And with this new perspective, it's just a totally different type of practice.
That's wonderful. I think you said it all there in terms of it's something that's going to be new. And I think everyone, Stephen, they kind of go, I find that people find niches, right? Some people
Right.
like wounds, some
Right.
like sports medicine, some like derm, some like nerve. And you probably, doesn't matter what you guys choose, whoever listening to this, but you have to find something you're passionate about and what you really like, but you have to be exposed to see if you like it or not.
Absolutely. Absolutely. And, when you sent the questionnaire to me, you kind of asked me, so I thought some very good questions, but,
Yep.
I think that, if you don't love it, don't do it. And
That's
if
brilliant.
and if you love it, then do it. But then if you stop loving it, you might want to stop doing it.
Yeah.
And, that's not so easy sometimes to make that transformation clinically. I mean, I didn't become 95% nerve overnight. It took, going on a little over 2 decades now.
Yeah.
And so we're changing that a little bit now with our nerve fellowship program, because these young practitioners are coming out, and you have to give them credit. I mean, they finish 3 years of residency and then they sign on for another 2 years of nerve fellowship. That's a big commitment. And you have to congratulate them for making that kind of a commitment, because they're looking at long term rather than short term.
Mm-hmm.
So, I think that changes that a little bit, that dynamic.
Yeah. And so now you are working on a film documentary about nerve decompression surgery. So is that for patients or is that for providers? Who's that going to be for? Tell me about that process.
Oh, it's great. Yeah, no, we've been working on this for about 3 years. And so Dylan came up with the concept that actually way back in the 70s, that many, if not most, of the symptoms of diabetic peripheral neuropathy are actually due to superimposed nerve compressions, because the diabetic nerve becomes edematous. So we're able to restore sensation in about 70% of properly selected patients, reduce pain in about 90%, but maybe even more importantly, reduce the annual recurrence rate of ulcerations, which is, I mean, as you know, the amount of healthcare dollars spent in wound care alone for diabetic patients is staggering. I mean, I don't have the figure on the top of my head, but it's a huge figure. So the general public doesn't know much about this. Most of the practitioners don't know much about it. And we felt that we just needed to get the message out to not only providers, but patients, and that there is hope. That's the important take home message here. And you can be decompressed, and you'll be, if you're properly selected. Again, you have to preface everything, this is not a panacea. It's not for everyone, but the purpose of the documentary is to at least make this resource known to both providers and patients. Now, it's probably going to end up constructed a little bit more for the layperson, but we have really incredible intraoperative footage, as well as interviews with very prominent folks in our profession. And it's being sponsored by the Association of the Extremity Nerve Surgeons. If there's any profit that is made from the documentary, then it will all go to the ANS Research Foundation. So it's more of I guess you could say, yeah, we'll benefit off of it from a marketing standpoint, but that's not the premise of it. The premise is we want to educate these people, let them know that there is something out there. And if we're able to raise some money for the research foundation, then that's even that much better, because then there'll be another level 1 study. And so it adds on. To give you an example though, it takes, the first 2.5 minutes of the documentary took 6 hours of editing.
Now,
So
no, you're not doing that. So who's doing that for you?
no, well, I'm sitting there next to the videographer and going through it, and it's very painstaking. But it's kind of one of the projects that I'm really very motivated by right now. So
Yeah, that's great. Let's talk a little bit about how you do so much. You mentioned you don't do it all yourself. Who do you have? Like, do you have a executive assistant? Do you have virtual assistants? How do you do it all?
yeah, well, that's a great question. I have some great staff,
Okay.
and one of the things that just kind of happened to me was I started teaching a class up at Kennesaw State University in Georgia. It happens to be a really large university, like 41,000 students. Before I moved to Georgia, I really had never heard of it, but it's got a huge biology program, pre-med program. And I'm teaching a course there now called Introduction to Clinical Medical Research. So we have 8 students a semester, and these are the brightest of the bright. And they all want to spend time shadowing, being in the office. So all of our medical assistants now are pre-meds. We have no regular MAs. And these are bright kids, and they want to be in that environment. And the one who really started all of this is essentially kind of like our back office practice manager. And he's able to, hire them, basically manage them from an employer-employee standpoint. And that's a rare find. You don't find that often. But what I've found with that, and then my partner, Dr. Ducasse, has a tremendous organization system, and she does a lot. I don't understand how she gets everything done that she does, but we make a pretty good team, and then we have good staff, and so it seems to work pretty well.
I like that idea. Someone else told me they use pre-med students as medical scribes in the office, very similar, because they're
Yeah.
passionate about learning terminology, and it's a win-win.
Right. And I have more pre-meds knocking on our door to do research or just intern. And some of them, unfortunately, they work for free because they just want the experience. They want their name on a paper. And, so
Yeah.
it's a good opportunity for them.
I think that's a key. And now you mentioned a little bit. I'm curious. Now you're a pilot as well. How did you get into that, or why do you fly? And
Yeah, well, I'm not current now, but it takes a lot of time, right? And I mean, if you want to be a safe pilot, you have to fly a lot. It happened because I really was scared of flying. I had a very significant fear of flying. And I was sitting in first class one day on a way to teach an endoscopy course. Because I flew so much, I had so many air miles. And it's like, man, I really don't like being on this. And I started thinking about it. It's like, if you consider yourself a man of science, then you really should look at this. And when I started looking at it, it's like, I got a much greater chance of dying in my car driving down to the airport than I do, especially on this commercial aircraft. So I thought it would be kind of an interesting thing to see if I could learn to fly to overcome my fear of flying. And it did overcome my fear of flying. It did take a lot more hours probably than a natural born aviator to do their first solo. But then I went on and got my commercial rating and my instrument rating. And I found learning to fly teaches you so much more than learning to fly, but it's hard to describe. When you're in the cockpit and you're the only one in the airplane, or you're, with passengers, there's nothing coming into your mind other than that cockpit, what do I need to do? How do I communicate with the tower? How do I land this plane safely? And I'm not thinking about next week's surgery, or I'm not thinking about, so it's kind of like a cool,
Almost like a meditative state almost.
yeah, exactly. It gets you in a zone where you just kind of tune everything out other than what you're focused in. So I found it pretty therapeutic, actually.
Yeah. And you did what you feared.
Yeah. But then I didn't fear it anymore.
Yep.
Say, once I learned it, and then I realized my fears weren't based on rationality, then, but that's we're all irrational. Humans are irrational beings, right? We just have emotional things in our makeup that have been passed down since we started, really walking the planet. But if you focus on something like that and you try to identify it, when you accomplish it, it's a tremendous thing,
Yeah, I'm totally there. And before you mentioned right in the beginning, and even right now, the importance of learning.
Right.
And I want to give some practical things, because if you were able to read 6 hours a week, I just think with 2 young kids, it's hard to find time. Are there certain systems or hacks that you have, like times of the day that you read? Do you set a block time to study? Do you like
Right.
what things work for you in terms of advancing? Because I think a lot of people, let's say they're interested in peripheral nerve, what I found now is 2 young kids, I gotta go to a course. I can't sit at home and read books for 6 hours because my kids won't let me. So courses are the best way for me to learn now.
Right.
How about you? Do you like to read? Do you like to go to courses? What do you recommend for people listening?
Well, I really like to read. And so I usually block out 1 day a week,
Okay.
just for academic stuff. If it's reading, it may be writing. Most of the time it's a combination of both.
Mm-hmm.
Now, I will tell you, my academic day gets blown up very frequently because, you're still taking care of patients and all these things. The other thing that I like to do is, if I'm commuting, I like to have a podcast on.
Mm-hmm.
And I always listen to something that is medically, or medical education, and usually not in our specialty, because there's really not that much in our specialty from
Mm-hmm.
a podcast standpoint. But I find that a very easy way to learn, rather than listening to music. So right there, if you're commuting half an hour or an hour, you can get in several hours pretty quick.
Yeah. I think those are 2 great resources. And then in terms of, you go and teach a
Right.
lot of these courses, do you, and hands-on, do you take other ones like in other specialties as well? Or are you pretty much too overwhelmed with just teaching these every weekend?
Well, no, I try to take as much. For example, next week I'm heading out to Reno for a ozone certification course, and that's totally outside of our specialty. But we do a lot of very interesting things. We also, I didn't mention, but we have an integrative medicine PhD in our practice. So she's able to look at, all things blood biomarkers and urine. And these folks will come in and, they may be loaded with mycotoxins. They've got mold in their house, right? So you have to assemble a team together to really try to bring a more of a 360 perspective to this patient. And so with that, we've brought in some very, innovative infusion therapies and those types of things.
And these are all in your clinic with your 2 other podiatrists, and so you have like almost like a functional medicine or integrative medicine.
Yeah.
There.
Yeah.
The fellowship.
Right.
So I think that's the trend. Everyone that I've been talking to is they try to incorporate other, even like endocrinologists, like you said, that you're trying to work on and things.
Right.
You know anyone else that does that in our profession?
I don't know. I mean, the university-based guys certainly do, but
Yep.
I think it's kind of unique, and I don't know why. It just makes so much sense. But the other thing too that became readily apparent to me when I first started down the peripheral nerve path was that while we were able to get a lot of people better, we still were unable to get a lot of people better. So we had to learn a lot more. And in medicine, and not just our specialty, but really all specialties, we're symptom treaters. And rarely does someone look at, well, why is this person insulin resistant? How are they sleeping? What are they eating? And it takes time to be I guess,
Detective.
I hate the word holistic, but I think if you really, and regardless in whether it's podiatric medicine and surgery or family practice or internal medicine, if you are able to prevent disease, that's the best disease.
Yeah.
And the problem is that there's not a lot of reimbursement for that.
Or reversing it. Yeah. Yep. There is
Exactly.
money in
Right. Or reversing it. I mean, we know that if you have a motivated patient, you can completely reverse type 2 diabetes. And that would seem like a heretical statement 10 years ago, but it's well proven now. And gastric bypass was one of the first things to show that.
Yeah, I asked my malpractice person about because I frequently recommend ketogenic and intermittent fasting. Usually,
Right.
The joke is I say if you need over 30 pounds, you eat every other day. If you
Yeah.
need less than 30 pounds, you eat one meal a day, and it'll get you there. I'm a
Right.
big advocate of that. Even without changing the diet, just doing the time restricted feeding works great. But they said, "Oh, you can't do that. You're a podiatrist." I'm like, if they're smoking, wouldn't I have an obligation to tell them to stop smoking? And yet I can't tell them to lose weight.
Yeah. See, I totally disagree with that. And I think that's one of the big things that's wrong with our profession right now. Now, while we have a limited scope, it's not limited in how you treat that. So if a patient comes in with peripheral neuropathy, I feel like if I have the knowledge base to treat that patient and I see that they're insulin resistant and I recommend intermittent fasting to them or time restricted feeding, and I give them, and the science is there,
Yep.
I don't see any reason why you
No.
shouldn't do that, because it's otherwise it's an incomplete or a partial treatment for that patient.
And those are the patients that, if they actually do it, not everyone does, the majority don't, but the ones
Right.
that come back in 50, 60 pounds lighter, they're thanking me. Their neuropathy reduces a little bit and,
Right.
things like that. So that's what brings joy, I think, is
Yeah.
helping patients, really helping patients that way.
Oh, absolutely. And then suddenly other things get better. It's like, oh, my retinopathy is improved, and I have better kidney function now.
Yeah.
And so we're all all a bunch of symptom treaters treating something that's a core disease. And there's a great book out right now that I'm just now reading called Metabolical, by a guy named Robert Lustig, and he is a retired 40-year plus university-based endocrinologist. And it's a great book because it's written both for the lay people as well as for physicians. So, I mean, you can, if you want, you can dive into the biochemistry, or if you want to just kind of gloss over that and read big picture. But the fact of the matter is that most chronic illness is really diet, lack of diet, exercise, sleep, and very little percentage wise is just true unfortunate genetic disease.
Yeah. Well, Stephen, we've talked about a lot of things. I'm going to put all these links underneath this video and podcast, including this book. As we kind of conclude, I'd like you to touch a little bit on regenerative medicine, if you use any of that in the nerve area, because it's very popular, amnio, PRP, stuff like that. And then just concluding, if people want to learn more about this, what's the best way to kind of get started with learning about more nerve surgery?
Yes, so regenerative is, I think, the wave of the future. Although we started injecting PRP and plantar fascia in 2001, so we're probably one of the first to do that. And then came amniotic stem cell, if you want to call it that. Now we're actually using peptides, which is pretty, it's revolutionary. So, and that's a discussion in and of itself. But if you want to learn more, about nerve, I would go to the ANS website. It's ANS.
I'll include it. It's fine.
You got it. Okay. But anyhow, yeah, no, we put on a great meeting. That's a great segue for you. If you have any interest in peripheral nerve, because we have speakers that have been in Nobel laureate labs. And so this is, kind of a different, well, it's totally different perspective than a regular podiatric surgery meeting, because we don't really talk that much about osseous structural surgeries and these types of things. We're more into, like last year, the meeting was focused on central nervous system, right? And so, it I think empowers you, because the more you feel comfortable with something, then you know how to refer it. And and then if you want to think about it from a practice management standpoint, it's very simple. You just become really as good as you possibly can, and realize you're still never that good, and you always have to keep trying, and you deliver the best care possible to those patients. And then all of a sudden your practice is doing very well.
That's great. Well, thank you so much, Stephen. This was a great interview. Learned a lot. I think it would be very helpful for everyone that's watching.
Look forward to it. Thanks for having me on.